Thank you so much for being here with us today. This is the Diverse Culturally Based Community Organizations and Researchers Collaborating for Improved Health session. When we meet, we always introduce ourselves, so I will go ahead and let Dorena start us off.
Dorena, Calvary Baptist Church.
Leanne Johnston from the Center of Excellence in Women's Health Program at the University of Utah.
Valentine Valentine with Best of Africa.
And my name is Ed Napia. I'm originally from New Zealand, but I work at the Urban Indian Center of Salt Lake, which was formerly the Indian Walking Center.
And Faina Tabakapasi with the National Tongan American Society.
Steve Alder with Family and Preventive Medicine and Public Health at the University of Utah, and also part of the Outreach and Collaboration team.
Janet Villata with the Hispanic Healthcare Task Force, members of CFU, and I'm the wellness coach.
Kathleen Tigri, and I'm the director of the Center of Excellence in Women's Health at the University of Utah.
Grant Sonata, public health PhD student and member of Community Faces of Utah.
And my name is Heather Coulter. I'm the community liaison with Community Faces of Utah, and also on campus at the university. I help build bridges between community leaders and academic researchers, scientists for the Center for Clinical and Translational Science. So today we're going to get started, and it'll go like this. We'll have about 10 minutes where Community Faces of Utah leaders, they will share with you who they are and how they do work. And then the next 10 minutes we'll have Dr. Kathleen Degree share with us about how it's really done, and she has an example project where we've worked with her for over 5 years, her team, to address women's health. So we'll go ahead and get to that point. Faina.
Okay. I guess just real briefly, as you can see, the Community Faces of Utah is made up of 5 different ethnic communities, plus the University of Utah, many different faculty members from the medicine department, the different departments, and also Brenda Rawls, who is an epidemiologist from the Utah Department of Health, is also a member of our coalition representing the Department of Utah Health, and so Utah Department of Health. So one of the things I think is really important just to share with you is the equality that we have as far as our ideas and sharing and things of that type. Like I said earlier, Reverend Davis likes to say that we put our egos at the door and we come in and everybody's on equal footing as we share our ideas and use our expertise to really come up with the best thing that we can do to assist and help our different communities get healthier. So that's kind of like the basic coalition idea.
Thank you, Steve.
And the work we do together, as Fahina was saying, we sort of check our egos at the door. Nobody comes in with titles, or there's no hierarchy. We come in as a group, we work together, and we work together as equitable partners, and that's a little different than equal partners. We're not equal partners because we all bring different things to the partnership, and so the equitability comes in that we value, though, everybody that comes and all that we bring together, and we look for ways in which we can come together, and as Ed has described it, we find that place of congruence when we work together. And if we're not at a congruent place, it means we're not through discussing and processing and figuring out where we need to be. So we've never had a vote. We've never had sort of a split committee. We don't even really function like a committee. That sounds way too formal for us. And we've worked. Heather has served as our facilitator for the years we've been together. But there's no chair of our group. There's no executive team. So when people come to work with us, it's always sort of fun to watch them try to figure out when they walk in the room, and we're sitting around the table. They're trying to figure out who's the person in charge, and the fact is, the whole group is in charge, and so it's really they have to engage and partner with all of us in order to work with us.
Yeah, I was just thinking a couple of minutes ago that, and I've been one to also say that we don't really have a hierarchy in our organization, but we do kind of have what I've decided to term a spiritual head. And that would definitely be Pastor Davis. And I look to him with great respect, and it's good because when I think about what I'm going to say, I don't ever want to offend him, so maybe that's a good thing. And then Fahina has a role too, because she's there to keep me in line.
Valentine, what do you think?
I mean, one thing that I love about our group, like they said, we are not equal. For example, the group I represent, Best of Africa, it's a group made of African immigrants here to Utah, new refugees. It's a new group of people coming from Africa. They don't know much about American system. But when I come to this group, I feel like I have a voice, you know, whatever contribution that we have, small, big, plus we learn from each other. They learn from us, we learn from them. And that gives a voice to the whole community, because as a refugee group, there are things resources that we are not able to get access to because of how small we are or how minority we are. But by joining our energy together, it gives power to all of us. And that's why I always feel like as a team, each of us ends better and becomes bigger. That's something I really love about our group.
Thank you. Dorina?
It seems really funny because it was a long time ago when we got started, and we didn't know what we were looking for. But we found out that we were looking for something that would make us all have something in common. And we found out that our health issues were all in common. We all had high blood pressure, we all had diabetes, we all had all these different diseases that we wanted to make ourselves healthy. So this is our common bond, is that we all have something in common. It's not just the color of our skin, which is not the same, or the texture of our hair, but we all have something in common. And so we were working for a healthier community. And so with this group, we've all found our ways to make our own communities healthier.
Thank you. Jeanette?
I think we represent the underrepresented community members, the ones that don't have a voice, like Valentine said. And what I like about this coalition is we have doctoral research, people with degrees, they have the resources, they have the funding, they have everything. But we have the problems in our community, right? And when they come to us and said, oh, maybe we can work on this, and that is absolutely amazing for us, because they give us the power to decide how are we going to approach our community. Maybe like she said, and we're going to work in nutrition, okay, a different approaching for the community, for her community, for my community, but it's the same goal. And they are coming to us to say how we can work with this, and they listen to us. And if each one of us said, oh, the best way to work in my community is this one, this one, this one, and say, okay, let's do it. And we do the work together, and that's what I love about this coalition. Thank you, all of you, because you empower us as community members, as a community-based organization. They empower us, and we empower our community as well. And that is a win-win approach for both researchers and us.
But, you know, it's not only our health conditions that bring us together at the same table very comfortably, but it's also the reason why we have these health conditions. The histories are the same, they just took place at different times. And so, you know, our ancestors, we like to think they were pretty healthy, and we still have inherited their bodies. We haven't evolved enough to deal with the types of foods that we have to eat now, the type of air that we have to breathe. Our bodies haven't caught up with our social evolution. And so as we come to the table, we can compare those stories because we're unhealthy for the same reasons.
Okay. Thank you very much. Let's get William, tell us how this really can be done.
Okay,
Wait, let's make sure.
oh, okay. Is it on?
I think
I'll just start. So we, the Center of Excellence in Women's Health received a grant from the Office on Women's Health to work with community-based organizations. And the project that I'm going to describe for you is called the Coalition for a Healthier Community for Utah Women and Girls. We call it UWAG. And it's really working with Community Faces of Utah, the Utah Women's Health Coalition, and the Center of Excellence in Women's Health. And you've met the Community Faces of Utah, and I don't know if this thing is going to work. Can you get that working again? Okay.
Go ahead and keep talking.
So the Community Faces of Utah, but also the University of Utah Center of Excellence in Women's Health and the Utah Women's Health Coalition. And a new partner that we've done as a demonstration project has been the Utah State University Extension Agents. And as you know, we have underserved people in Utah. We have a very urban population, but we also have a very rural or frontier population, and we've been able to work with them as well. Our first year, we received planning funding, and we did a needs assessment for women's health in Utah, and we identified obesity and prevention of diabetes as our primary goal. And I met Louisa Stark and Heather and Steve Alder, and we were able to work with the Community Faces of Utah to come up with a grant that was successfully funded, and we're in year 5 of that grant. But I want to stress that we really went to work with Community Faces of Utah to say, what is it you need? And one of the things that I remember Ed saying at one point was, well, we need an expert in each community, like some kind of coach or some expert that we could each have. And so that's how we came up with the idea of what we were going to do. And they agreed that they wanted to work on reducing diabetes by working on nutrition and physical activity. So we developed a community wellness coaching program, and really was co-developed. This was not us coming in with the program already done, but we developed it with the CFU leaders. We worked with our CCTS, and we used community-based participatory research principles of working with the community in a bi-directional way. Our coaches learned motivational interviewing and helped women set goals for themselves. We used practical strategies to increase healthy eating and active living. And group activities were actually shared among the wellness coaches. They met monthly, shared, well, what group activity is working for you? And we wanted to think holistically in everything that we did. One of the programs that we subscribe to in the Center of Excellence in Women's Health is the 7 domains, that health is not just physical health. And as we heard today, our social health affects how we do our mental health, intellectual health, environmental health, financial health, and of course spiritual health. And our coaches were recruited from each community. Most of them would speak English, but we have Spanish coaches, we had Kirundi speaking coaches, and we had to translate our materials. We actually did a randomized controlled trial, and we're just finishing this up. The participants were recruited by the wellness coaches from their own community, and we asked a research question. And the question we initially were supposed to ask, because our funders wanted a randomized controlled, meaning control people that don't get anything. But when we went to the Community Faces, they said, no, our participants all get something. So together we crafted our primary outcome, which was is a community wellness coaching program more effective in decreasing obesity risk factors when administered monthly? That means intense, high intensity, versus 4 times a year, which would be just checking in and seeing how the person's doing with the goal. And then we asked the question, is that high intensity worth the additional cost? So we developed questionnaires, working together on questionnaires and protocols. We used the REDCap database. Every coach learned how to use the REDCap database. We had it translated into 3 different languages. The database actually had coaching prompts that could be used. The leaders recruited the wellness coaches, and in some cases, leaders had to recruit several wellness coaches because some people got jobs and couldn't continue doing the job. All of us were trained, and the leaders were trained, and the wellness coaches were trained in HIPAA, in research trainings, the city training. The wellness coaches were given wellness coaching trainings, and we collected data that has been stored on REDCap, and each community has access to its own data. We found that in our data collection, it really, we had to work with the wellness coaches, and they did a marvelous job. They interviewed all of these participants about health knowledge, their behaviors, perceived benefits, perceived barriers, what kind of social support each person had, and we asked about mental health, and we actually had mental health questionnaires. We measured blood pressure, body mass index, the waist to hip ratio, and the women each set a goal, either a nutritional goal or a physical activity goal, and then some very ambitious participants would do both. But the women set their own goals of what they wanted to do. And now these are our results. So we wanted to enroll 400 women into the program, 80 per community. We have completed 500 baseline interviews. We've completed 351 4-month interviews, 308 8-month interviews, 239 12-month interviews, and we're finding at 12 months of the 12-month results, 70% have been successful or very successful in meeting the goal that they set for themselves. At 8 months, we found that there was amazing improvement in depression scores, and Grant Sanudas actually looked at this and found that initially our PHQ-3 scores, our depression scales, were up in the 22 to 25% of women meeting a definition of depression, and at the 12-month interview, we were down to 10%. So we had impact on mood. We saw a very nice increase in fruit and vegetable consumption, up to 67.8% at 1 year, and also increased physical activity. And then we did, our primary outcome was not weight loss, but we did keep track of weight, and we did find that 5% or more of body weight was lost by 22% of the women. That means 1 in 5 women lost 5% of their baseline weight at 12 months. And that was not what we were setting out to do, but when 90% of the people that we saw were either overweight or obese, this was quite striking. We partnered with the professor of economics, Norm Weitzman, Kathleen Zick, and one of his graduate students, Iris Booter, to actually study cost effectiveness of this intervention. And we've got cost effectiveness ratios and cost benefit ratios, and we've looked at QALYs, but our cost effectiveness ratio is actually in the top half of similar programs that have been done in looking at improving physical activity interventions. We've learned many lessons along the way. It takes a long time to do this kind of project. This is a 5-year grant, and we're in year 5. We've also learned that bidirectional learning is really important because we learn from the community and they learn from us. We learned about putting our egos aside to work together. And to work together, we have to solve problems. One striking thing that was brought up this week, or a couple weeks ago, that I think is really important, is the importance of meeting women. You also get their households. So while we enrolled 500, we did 500 baseline interviews with women, we reached almost 3,000 people in the household by just working with women. And Jeanette can tell us many stories in her community about the effect of on the family members by helping the women. Maybe you could just share that with us.
Yeah, like I was saying before, working in our community, one of the first success stories that we had is when we work with the woman in the household, she is mostly the primary person that buy the groceries at home. And when we work with her, and she is aware to the power that she has at home, she's starting to think by herself and empowered and saying, if I get soda, my kids is gonna get soda. They're gonna get sick at some point. And our work as a coaches is to plant that seed of awareness. Give her the power to say, you are in charge. And when she feels that she is in charge, she can change everything around her. It's a big work around because we have, like doctor saying, we have to work emotionally, socially. We have to do an assessment with her to see what is the micro environment and the macro, to use all the support that she has and empower her. When she is empowered, she is going to be in charge of the family, and she's going to take more healthy decisions around the family. And that's one the successful story that we have, because we're starting to changing the way the kids are eating. One of the families, the son lost like 20 pounds in the first 2 months just to make some changes. And for that family, that was empowered, for them to see that they are in charge of their health. And that's one of the successful, I can tell a lot of successful stories, but I think the impact of the family that we're doing is
Actually, it goes beyond just the family, it goes to the whole community. One of the successful stories we have in our community, when new refugees are coming from Africa, they need a place where they can go buy food that they are familiar with, food from our countries. So every month, as part of the group, we do a monthly activity for women. They get together, socialize, go to the park, go exercise. So one of the good things that came out of that is women involved in that group, they get connected to the women, new arrivals who are just coming from Africa, and then they show them where to buy food from their country, they show them around. So as a result of the monthly activities we do, so it goes beyond individuals, it goes beyond just a family, it attaches the whole community.
That's a great point, Valentine.
And I want to support that too. And I'm learning a lot of lessons, and one of the main lessons is that, according to what I think, I don't know everything. And so we make some cultural assumptions about our community. Oh, Indians are never going to like Zumba. Why don't you do Zumba that's in an Indian style? Well, wrong. We started off with 2 nights a week, and people started saying, well, that's not enough. So now we have Zumba at our agency 3 nights a week. But the other lesson is that, I've always believed that health is a family affair. But to always find a mechanism by which we can accomplish that is not always easy. Well, now families are coming to Zumba, and so the kids are exercising with their mothers. Now, in one particular family, their adopted daughter is a little overweight, and she was dancing at the back, or doing Zumba at the back with her family, and then the instructor invited the younger kids to come up front because they've got more energy, and she went up there and she tried it as hard as the rest of them. So it's something that is really making us feel like we're accomplishing something great in our community.
That's great. And I just want to, we could go on and on about lessons, but we've collaborated on everything. This is one of our first publications. And as you can see, all of the leaders are members of are authors, and we talked about what is authorship, and they met the criteria for authorship. And even though we had to go to bat with the journal editor to get this many people on the journal, we were successful. This kind of collaboration has another product. We just submitted 12 abstracts to the American Public Health Association meeting for next fall. 5 of them were authored by a leader of their community to their community caucus, which for me, I just thought that is the best it's just cool. And 5 were authored by students in public health, and they were mentored by Sarah Simonson, who really should be the one giving this presentation today, but she's on vacation. And but she has been an amazing force. She's a force in the Department of Family and Preventive Medicine and Public Health. So I would say that that we are learning that we can do this work together. It does take more time, a little more time, but the product is way worth all the time that's put into it. And this work is not done by a single individual, it's really done by a whole community working together to address a problem.
Thank you very much.
I'll
Okay.
turn it back to you, Heather.
Thank you. So for the next 8 to 10 minutes, we would like to break up into small groups and have the people from CFU and Utah Women's and Girls Coalition come and have conversations with you regarding, and it can be what you choose, but we do have it's okay, 3 questions will make it a little easier to see. The first is approaches that support successful collaborations, barriers and challenges to successful collaborations, and then what research topics could communities and research engage in collaborative research. Those are some topics that you can choose to discuss with the experts from the panel, or if there's something else pressing, please feel free to do that. There are chart paper around the room, so in your group, please record your conversation and then be prepared to share out in the last 10 minutes of our session. Are there any questions?
Join a group.
Yep, create small
Come around the table.
groups of 3 maybe. We've got enough experts up here. Ready to share out? Who's ready? Grant, did you just say first?
Serendipity, that's one of our themes though. Serendipity.
Okay, who's the lucky spokesperson?
Sorry,
And then someone put your number at the bottom of that so Sarah we can contact you and know what that is. I'm joking.
Okay, I'll try.
Okay, we're ready.
Okay, so we had a very robust conversation in our group, and it kind of started with the question about how do you even begin to create a coalition and understanding better the history
Okay.
for your organizations, which kind of led us to that thought of we really always need to have common ground, right? And so in that context, we kind of moved across the questions and really wanted to kind of look at this sort of sweet spot, right, in our Venn diagram of how do we, that common ground definitely helps us address barriers, break down those barriers, helps us also be successful, but also helps us also understand where the research and the community comes together to create opportunities or projects that really are value added for the community, and also really using our community partners in a way that it helps translate what the researchers thought our idea might be in a way that's involving the community from the get-go, and helping then with our key community partners, them being able to translate it in a way that it will be successful based on the cultural dynamics of their communities. Wow. Did I miss anything?
That's so
good. Okay.
That's a great
It was the team. It was the team approach. I was representing the team.
Valentine always says team means together everyone achieves more.
Exactly. I love that.
Great job. Okay, next. In the middle here. Who's the spokesperson, the lucky?
All right, so we had a good together of researchers and community members, I think, in our group. And wasn't expecting to be the spokesperson, so I will not be nearly as eloquent as that. But we talked about some of the approaches that we are trying to change. It's really interconnected with the barriers, though. But sort of the barriers that we face as researchers are this lack of connection that prevents us from getting community members involved in the beginning, which we're trying to do more. So one of the things that we asked the representatives here of the collaboration was whether that's something we could bring to your group, and we got a positive answer that yes, maybe that's somewhere that we can go where we can start to make connections with the community early on, even before the grant's written, rather than writing the grant, designing the questions, and then coming. And we talked about the challenges of it's hard to find people who have the bandwidth to participate, both at since everyone has mentioned, it takes more time, both from the researcher's side and the patient side, to have this collaboration. So we talked about, you know, one of the things that could make that successful is if you're getting multiple benefits from that collaboration. So I think one of the powerful things about the work that's been done that you discussed earlier was the fact that people both socialize and exercise, both socialize and learn to cook, so that you're getting, people are really getting a lot out of that collaboration. And so building collaborations where that's possible for people to do. And then other topics to pursue, we talked about looking more into health issues and then especially chronic disease and prevention.
Okay, thank
You
you.
guys wanna add anything?
Good job.
Exhausting.
Thank you.
Okay,
Okay.
who's the lucky?
I guess I'll go. So we've focused mostly on our discussion around asthma,
Okay.
because me and Heather, we work with Dr. Nicoy, who presented earlier today.
Okay.
And so we were interested in how we could expand our work into the community, especially in the minority communities, like the Hispanic. So we thought some of the approaches that we could take were to approach those who have high power in the community and a high influence, identify who the community leaders are and how we could build trust and relationship with them. And also we would need to assess what the community needs and how they could benefit, as well as how we could benefit from them. Then we can learn from each other, something that's already been said. And we would also we would need to adapt the tool, the asthma tracker tool, into Hispanic, not only by language but also culturally as well, and what works for their community. What worked for our study in our population might not work for this new population, so we had to find out what they need and what's important for them. And we also talked about kind of taking a new approach instead of just doing the traditional survey and focus group. Something like what Dr. Rich from Boston did in that video we watched. Just giving them like a video camera or some new approach to help them identify what's important to them at home instead of just filling out a survey in like 5 minutes. But right, yeah. And we also talked about maybe connecting with the community health workers and community organizations to and partnering with them to be successful in our efforts.
Great. Okay, thank you, fantastic. Any other, we've got a couple minutes, so.
I want to add one thing I forgot to say. 'Cause
Great.
It was really powerful for me. So sometimes I think just by the methods we choose, we are excluding people without meaning to. And the
Okay.
reason that I say that is because I am a data analyst, and so a lot of the work I do is pulling information from medical records. And so, I'm sorry, I don't remember your name. Dorina. I didn't say that right. Can I see it just so I can say it right? Dorina. Okay. So Dorina said that, you know, if we are looking only at medical records, we're not getting the uninsured patient who doesn't have the money to come into the doctor. So we're looking at this very selective group of people. We're missing the health, one end of the spectrum, you know, the healthy people that aren't coming in, but we're also missing, completely unintentionally excluding the entire range of patient experience. So I think sometimes to get over these barriers, it would require complete redesign of how we're doing the work we're doing.
Fantastic, okay, I think I captured that. Okay, well, thank you very much. I know Sarah will gather all of these ideas and see if we can change the world together.
That's awesome.
Okay, good.
All right, thank you, Heather.
Thank you so much. Round of applause.